Hello everyone, welcome to my YouTube channel. Today I am going to talk about necrotizing fasciitis part 1. Before we start, there is a disclaimer. This video is for informative purposes only. I am advising you to refer to the main textbook or sources that is used in each teaching center respectively. Thank you. Now let's begin. So what is necrotizing fasciitis? Necrotizing fasciitis is a life-threatening condition. It is a rapidly progressive skin infection characterized by infection of the fascia and fascial plane and necrosis of the muscle fascia and subcutaneous tissue. Necrotizing fasciitis is a subset of aggressive skin and soft tissue infection, SSTI. Etiology. Necrotizing fasciitis is typically an acute process occurring rapidly within several days. It is a direct sequelae of bacterial infection introduced through a break in the skin integrity. Causes are due to A. Identified trauma, either minor or major trauma. B. Surgical wound. C. Injury by fish fins. The common organisms are marine bacteria, namely Vibrio species, Aeromonas species. Comorbidities: higher in patient who has poorly controlled diabetes mellitus, in obese patient with underlying liver cirrhosis or chronic renal failure, immunosuppressive patient, cancer patient on chemotherapy drugs, SLE, systemic lupus erythematosus patient on steroid. It can be divided into 4 types. For type 1, it involves polymicrobial organism. Among the organisms are non-group A Streptococcus, anaerobes including Clostridium organism, Enterobacteria. Type 1 is the most common necrotizing fasciitis. Commonly seen in immunosuppressive patient, example in diabetic patient, cancer patient, in liver cirrhosis patient. For type 2 necrotizing fasciitis, it involves monomicrobial organism. Commonest organism is group A beta hemolytic streptococci. It mainly seen in healthy patients, characterized by vascular thrombosis and cutaneous gangrene. Often with severe systemic toxicity, patient is in toxic shock syndrome condition. For type 3 necrotizing fasciitis, the commonest organism is marine Vibrio vulnificus. It is a gram-negative rod. Patient usually infected due to marine exposure, example, accidentally skin being pierced by the fish skin hook. In type 4 necrotizing fasciitis, the commonest organism is methicillin-resistant Staph aureus, MRSA. Usually occur in immunocompromised patient, example, in HIV patient or in AIDS patient. Based on classification of necrotizing fasciitis, we can decipher that the classification is based on microbiological or organism involved. Pathophysiology of necrotizing fasciitis. Infection begins in the hypodermis or superficial fascia. Dermis and epidermis not affected in the beginning. The infection rapidly transits the muscle fascia. After several days, the overlying skin, which appears unaffected initially, will turn to an erythematous reddish-purple to bluish-grey. The texture of the skin will become indurated, swollen, shiny, and feel warm in temperature. The skin is very tender on palpation, with pain out of proportion to the presenting symptom. Skin breakdown will begin 3 to 5 days later, and it is accompanied by bullae and cutaneous gangrene. Pain is reduced in the affected area secondary to thrombosed small vessels and destruction of the superficial nerve in the subcutaneous tissues. Advanced stages of infection are characterized by systemic symptoms such as fever, tachycardia, and sepsis. The extension of infection and necrosis is facilitated by the synergy between different bacteria and toxins and the enzyme they produce. An aerobic environment promotes the growth of anaerobic bacteria. Necrosis of the hypodermis and superficial fascia is related to bacterial enzymes that destroy the fascia and fat, and secondary to vascular origin. Invasive bacteria cause thrombosis of nutrient vessels, leading to tissue ischemia, aggravated by presence of edema. Apart from history and physical examination, the Laboratory Risk Indicator for Necrotizing Infection LRINEC score is helpful in diagnosing necrotizing fasciitis. It involves 6 blood parameters. Score more than 6 has probability of 92% of patient having necrotizing fasciitis. The first score is CRP in milligram per liter. More or same than 150 is given 4 points. Less than 150 milligram per liter, 0 point. 2. Total white count, WBC count, per cells per millimeter, less than 15, 0 point. 15 to 25, we give 1 point. More than 25, we give 2 points. 3. Hemoglobin in gram per deciliter. If the hemoglobin is more than 13.5, 0 points are given. The hemoglobin is between 11 to 13.5, 1 point is given. Hemoglobin is less than 11, 2 points are given. 4. Sodium in millimole per liter. If less than 135 millimole per liter, we need to give 2 points. If more or same as 135 millimole per liter, 0 points are given. 5. Creatinine, micromole per liter. If creatinine level is more than 141 point, we give 2 points. And lastly, glucose in millimole per liter. Glucose is more than 10, we give 1 point to the patient. Whatever it is, the diagnosis of necrotizing fasciitis is still a clinical one. Differential diagnosis of necrotizing fasciitis include 1. Cellulitis, 2. Gas gangrene, 3. Toxic shock syndrome. I am going to cover regarding the differential diagnosis in another video. So what is the management of necrotizing fasciitis? This patient is usually ill and need aggressive resuscitation. The sepsis will cause refractory hypotension and diffuse capillary leak. Thus, patient will need aggressive resuscitation with fluid and inotrope. We commonly use inotropes are noradrenaline and dopamine. We can do a finger probe test. It is a bedside procedure performed under local anesthesia by which a 2 cm incision is made down to the deep fascia. And then the gentle probing of the index finger is applied. The presence of characteristic dishwater pus along with the lack of bleeding and lack of tissue resistance to blunt finger dissection are the findings correlated with necrotizing fasciitis. Imaging tests. Plain radiography have low sensitivity and specificity. Around 30% shows gas shadow formation in the soft tissue. And absence of gas shadow does not exclude necrotizing fasciitis. CT scan shows extent of tissue infection, facial swelling, and inflammation with gas formation. It has sensitivity around 80%. An MRI provides better accuracy, but not widely used due to the cost. It has 100% sensitivity, specificity around 86%. Ultrasound is used when the diagnosis is unclear. Findings in ultrasound is hyperechoic foci with reverberation artifact and dirty shadowing at the site of infection, representing subcutaneous gas. The problem with ultrasonography is that it requires a highly skilled operator. Operative management is the mainstay of treatment. Patients need to undergo emergency radical debridement with broad-spectrum intravenous antimicrobial therapy. Operative findings are liquefied subcutaneous fat, dishwater pus, muscle necrosis, and venous thrombosis. In some patients, a second look surgery may be required. Wound need to be left open for dressing. For antibiotic treatment in necrotizing fasciitis, empirical usage of antibiotic is based on microbiological classification of necrotizing fasciitis. For type 1 infection, ampicillin or ampicillin and sulbactam combined with metronidazole, clindamycin or carbapenems or imipenems are used. For type 2 infection, either first or second generation of cephalosporins are used. For type 3 necrotizing fasciitis, clindamycin and penicillin can be used to cover the Clostridium species. If Vibrio infection is suspected, early use of tetracycline, including doxycycline and the third generation of cephalosporin, is very beneficial. For type 4 necrotizing fasciitis, make sure to add intravenous vancomycin for the MRSA infection. The continuation of each antibiotic depends on the blood and tissue culture. Okay everyone, that's all for today. I am going to cover regarding role of hyperbaric oxygen therapy, HBOT, in part 2 of necrotizing fasciitis with other additional questions. I hope you can learn something from this video. Till we meet again. Bye.